Okay, hi everyone. I'm Just Great. I'm here to talk to you about osteoporosis today. So I have no conflicts of interest to report. The one disclosure I'll make is that I'm not an expert in this subject. I picked it as a way to challenge myself and do a deep dive and get more comfortable with managing osteoporosis in the outpatient setting. So hopefully after this talk, you will also find this topic a little bit more manageable and feel more confident in managing osteoporosis in the outpatient setting as well. So my objectives for today are to define osteoporosis, review the epidemiology, review criteria for screening, review recommended management. So let's start out with a case. And the point of this is not to be able to answer it right now, but hopefully to be thinking about it and further along in the presentation based on the information I give you, hopefully you'll feel more confident answering how to handle this situation. So you have a 55-year-old postmenopausal female. She has a history of rheumatoid arthritis. She's on prednisone, and she also has a history of GERD. She comes to establish care with you, and she states she's concerned about developing osteoporosis as her mother suffered from a hip fracture at the age of 67 after a ground level fall. So the question is, what do you do in this situation? So like I said, just kind of hold on to that and think about that as we move forward, and hopefully the answer will become clear in a little bit. So let's start off by defining osteoporosis. Osteoporosis is a skeletal disorder characterized by compromised bone strength leading to an increased risk of fracture. So if you look at the image right here, it shows normal bone with increased tensile strength and a thick bony matrix. And then if you look at the osteoporotic bone, the connections are very fragile and weak and look like they're about to break pretty easily. There's also primary and secondary osteoporosis. Primary osteoporosis is postmenopausal or senile osteoporosis that happens due to hormonal changes that happen with aging and just due to normal bone loss that occurs with aging. Secondary osteoporosis is due to other causes such as medication use or certain diseases that lead to bone loss at an accelerated rate. So moving into diagnosis, there are many ways to diagnose osteoporosis. The WHO says in postmenopausal women and elderly men, you can diagnose osteoporosis by looking at something called a T-score. And the T-score represents the number of standard deviations away from average bone mineral density for young, healthy individuals of the same birth sex your patient is. So if you turn your attention to the figure, if your patient's T-score is negative 2.5 or lower, they're in the osteoporosis category. If their T-score is -1 to -2.5, they're in the osteopenia or weak bones category. And if their T-score is -1 or above, then they have normal bone mineral density. And a note about T-score, it's been really well studied and well defined in postmenopausal cis females. It hasn't been well studied or well defined for cis men and members of the trans community. So more research needs to be done in that area. And then a note on premenopausal women. For premenopausal women, we use something called a Z-score to diagnose osteoporosis. And Z-scores look at bone mineral density of individuals of the same age and birth sex and race. So if your patient has a Z-score of less than -2, that's below expected age range, and that should prompt a workup for secondary osteoporosis. So moving on, like I said, there are many ways to diagnose osteoporosis. You can also diagnose osteoporosis clinically after your patient sustains a fragility fracture. And a fragility fracture is a fracture that occurs from minor trauma that ordinarily would not lead to fracture. So this would be if your patient lifts a heavy object and sustains a vertebral fracture after lifting something heavy, or they slip and fall on the ground and sustain a hip fracture. So things that we wouldn't ordinarily think of leading to fractures. The last way to diagnose osteoporosis, according to the American Association of Clinical Endocrinology, is that you can diagnose osteoporosis if your patient has a T-score of -1 to -2.5 and a 20% or greater risk of an osteoporotic fracture or a 3% or greater risk of a hip fracture based on the FRAX calculator. If you turn your attention to the FRAX calculator on the right side of the screen, it looks like things such as your patient's BMI, your patient's sex, whether they have rheumatoid arthritis, whether they use glucocorticoids to determine their fracture risk. One pitfall of this is that there are many more things that can put your patient at risk for osteoporosis aside from these 12 things, so it may underestimate fracture risk for a lot of individuals. And to epidemiology, 11 million individuals are affected by osteoporosis, 2/3 of whom are postmenopausal women. Osteoporosis is a silent disease. It is often diagnosed in individuals without underlying risk factors who are asymptomatic, which is why screening is very, very important. Hip fractures affect approximately 15% of females by the age of 80 and 5% of males by the age of 80. And if you turn your attention to the figure, this is a breakdown of the types of osteoporotic fractures patients faced in 2015. So in 2015, there were 1.6 million new osteoporotic fractures in Medicare beneficiaries. And the most common type of fracture was a spine or vertebral fracture, as you can see by that yellow wedge. The interesting thing about this is that 60% of vertebral fractures are actually asymptomatic, so patients don't actually know that they have them. And we find them on imaging obtained for other reasons. And anecdotally, I've seen this in the hospital where I've ordered a chest CT and noticed that the patient had a vertebral fracture and they had no idea that they had it because they're not in any pain. They don't know when they sustained it. They don't remember any traumatic fall. So I think the important thing to note here is if we do find a vertebral fracture on imaging, is to talk to our patients about it and just say, just so you know, when we got your CT chest to look for an abscess, we noticed a vertebral fracture. Are you aware of it? Have you talked to your doctor about it? This puts you at high risk for other osteoporotic fractures. So it's important when you leave the hospital to talk about getting treatment for this. So a couple notes on disparity. So after adjusting for insurance status, women of African ancestry were less likely to be referred to a DEXA scan. Also, after adjusting for insurance status, women of African ancestry were less likely to receive treatment after diagnosis of osteoporosis or sustaining a fracture. Women of African ancestry also have the highest rate of mortality after sustaining a hip fracture. And one thing I will say is from the studies I've seen in the literature and the numbers I've seen, women of Caucasian ancestry are more likely to sustain any type of fragility fracture compared to individuals who identify as other races. And historically, women of Caucasian ancestry were more likely to sustain a hip fracture than any other group. But in 2010 to 2016, if you look at the data for Medicare beneficiaries during that time, it seems like the population of individuals has shifted now. And during that time, women of African ancestry were more likely to sustain a hip fracture than any other group. So the population that this disease is affecting and impacting most significantly is definitely shifting. A couple more notes on disparities. So T-scores are based on individuals of Caucasian ancestry. So there is thought that they underestimate the risk of fracture for individuals of the African and Hispanic populations. The FRAX calculator was developed primarily based on individuals of Caucasian ancestry. So there is thought that the FRAX calculator underestimates the risk of fracture for individuals who identify as Asian, Hispanic, and African American. I also just want to make note that data on disparities for Native American, Asian, and Hispanic populations is limited, so more research needs to be done in this area as well. So moving on into screening. So the U.S. Preventative Services Task Force, the American Association of Clinical Endocrinology, and the National Osteoporosis Foundation recommend all women at the age of 65 and all men at the age of 70 should receiving a screening DEXA scan. You want to evaluate all your postmenopausal female patients over the age of 50 for risk factors of osteoporosis. And you really want to consider getting a DEXA scan before 65 for women based on their risk factors. And one thing that I really want to emphasize to everybody is that osteoporosis is severely underscreened for. One study I looked at showed that only 34% of individuals who identified as Caucasian who met criteria for screening DEXA received one. And sadly, only 8% of women who identified as African American received a screening DEXA when they qualified for one. So there's a lot of work to be done on screening and by extension, treating this disease and preventing fractures in the future. And I was trying to read in the literature to figure out why this was, and it might have to do with the fact that in the last 10 years, Medicare has decreased the reimbursement for DEXA scans, and there are less locations for DEXA scans as a result of that. So moving on, who's at risk for osteoporosis? So I have a list of modifiable and non-modifiable risk factors. So cigarette smoking puts your patients at risk for osteoporosis, low BMI, low calcium intake, low vitamin D intake, having recurrent falls, alcohol use, and inadequate physical activity are all modifiable risk factors that we can counsel our patients on to hopefully help them change some behaviors and prevent them from developing osteoporosis. Some non-modifiable risk factors are advanced age, Caucasian ancestry, prior history of a fracture as an adult, female sex, history of hyperthyroidism or hyperparathyroidism, history of chronic kidney disease, premature ovarian failure, hypogonadism, diseases like lupus or rheumatoid arthritis leading to chronic steroid use, and use of an aromatase inhibitor. So going back to our case, you have a 55-year-old postmenopausal female with a history of rheumatoid arthritis on prednisone and GERD. She comes to established care with you, and she's really worried about developing osteoporosis because her mom had a hip fracture. So what do you do in this situation?
Give me 1 second to just relaunch the poll here.
Okay,
Great. While that poll's running, just Jaspreet, one question has popped into the chat about any thoughts on how to screen non-cis people on hormone replacement therapy.
That's a really good question. I have not found much data on that in the literature in terms of recommendations. I imagine if the hormone replacement therapy is estrogen, that it would actually be protective against osteoporosis.
Yeah, Kevin says screen based on hormone profile.
Okay, great. So it looks like most people got this question correct. So the answer is E. So the reason why is inadequate calcium and vitamin D intake increases your patient's risk of fracture. And then this patient has rheumatoid arthritis and is on prednisone and has a family history of a hip fracture, which are all things that put her at risk of developing osteoporosis, and are all things that are taken into account on the FRAX calculator. Okay, so continuing on, you decide to counsel your patient on adequate calcium and vitamin D intake, as well as order a DEXA scan. The DEXA scan shows a T-score of -2. What would you like to do next? Okay, great. The answer is C, calculate your patient's FRAX score. It seems like, as you guys remember, if you are in the osteopenia category based on your DEXA scan results, then you can also meet criteria for osteoporosis depending on your FRAX score. Okay, so you calculate your patient's FRAX score, and she is at 23% risk of a major osteoporotic fracture and a 2.3% risk of a hip fracture. So does your patient meet criteria for osteoporosis? So the answer to this is yes, she does, because she's at a 23% risk of a major osteoporotic fracture and her T-score is -2. So the question then becomes, what do we do next for this patient? So the American Association of Clinical Endocrinology recommends evaluating for secondary causes in all individuals diagnosed with osteoporosis. Ordering a CBC, CMP, and serum vitamin D is a reasonable place to start, and further workup would really depend on findings in history, physical exam, and initial labs. As you can see on this table, there are a ton of secondary causes of osteoporosis in adults. So the point isn't to memorize this table, but it's to just be aware that there are a lot of things that can cause secondary osteoporosis. And if your patient is complaining of a lot of digestive issues and has a low vitamin D, you might want to think about screening for celiacs, or if they meet some criteria for multiple myeloma, like Adam just talked to us about, maybe screening for that. So just something to keep in the back of your mind when you see a patient initially diagnosed with osteoporosis. So moving on into treatment, it's always good to start by counseling your patients on lifestyle modifications such as smoking cessation, limiting alcohol intake, and then 30 minutes of exercise 3 to 4 times a week is important. It's been shown to significantly increase bone mineral density in patients. Progressive strength training has been shown to be the most effective at increasing bone mineral density. And one thing that I really want to emphasize here, it's important to counsel your patients on picking an exercise or an activity that they like, because long-term adherence is super important, as the positive effects of exercise on bone mineral density are reversible if exercise is stopped. So being persistent with an activity regimen is really key. You also want to counsel your patients on focusing on fall prevention. So when you diagnose osteoporosis, talk to your patients about balance, and if they're having trouble with balance, refer them to physical therapy if they're saying that they're struggling with that. Ensure that they have a cane or a walker if they need one. Talk to them about removing fall risks from their house, such as securing rugs. The other thing that you should do is just look at their medication list to see if there's anything on the list that would make them dizzy or hypotensive or an increased risk of a fall. After that, you want to counsel your patient on adequate calcium and vitamin D intake. Generally, the recommendation is to ensure you get 1,000 milligrams to 1,200 milligrams of calcium a day and 800 milligrams to 1,000 milligrams of vitamin D intake. Oral sources are preferred, but if your patient can't get it through like an oral dietary source, it's okay to supplement with vitamins. So I want to talk about a little bit where we get that recommendation from vitamin D and calcium from. So basically, there was a study done where individuals with a mean age of 84 were separated into 2 groups. You had your intervention group and your placebo group. So the intervention group got 1.2 grams of calcium and 800 milligrams of vitamin D3 every day for 18 months. And the placebo group got sugar pills. So the top line is on both graphs the placebo group, and the bottom line on both graphs is the intervention group. So as you can see, there is a decreased rate in hip fractures and other fractures in both the intervention group that received the calcium and vitamin D. The one thing that I'll make note of is that there's some recent controversy in the literature over supplementing with vitamin D. The Women's Health Initiative does support this data and showed that calcium and vitamin D supplementation did lead to increases in bone mineral density and help prevent osteoporotic fractures. But more recently, there have been studies about bolus dosing vitamin D, and the studies have found that if you're bolus dosing more than 24,000 units of vitamin D at 3 month intervals or yearly intervals, your patient's at an increased risk of fall or fracture. So my big takeaway from this is that oral supplements are best and limiting how much somebody gets each day. But if your patient is severely vitamin D deficient when you test them, what you could also do is weekly supplementation with 5,000 units of bolus dosing. So moving on into pharmacological treatments, I'll start by talking about bisphosphonates. So if you turn to the figure, we can go over the mechanism of action a little bit. So the bisphosphonate is represented by the green dot. So the bisphosphonates accumulate in the bony matrix, and they're taken up by the cells called osteoclasts, which break down bone. And when the osteoclasts take up the bisphosphonates, it causes apoptosis, preventing further bone breakdown. There are oral and IV forms of bisphosphonates. It's important to note that bisphosphonates have low oral bioavailability. So when you're prescribing them to your patients, you want to counsel your patient to take bisphosphonate on an empty stomach, counsel them to sit upright and avoid food for 30 minutes after taking the medication. It's also important to replete your patient's vitamin D before starting bisphosphonates, because vitamin D can improve your patient's response to the bisphosphonate and lead to further increases in bone mineral density. And then a note on some contraindications of bisphosphonates. So if your patient has a creatinine clearance less than 30, they can't get bisphosphonates. However, if your patient has an esophageal motility disorder, such as a Roux-en-Y, or a severe hiatal hernia, they can't get oral bisphosphonates, but they can still get the IV form. Furthermore, if your patient has GERD, that's not a contraindication to an oral bisphosphonate, but the IV form would be preferred because bisphosphonates increase the risk of piloesophagitis. And then a note on some critical side effects we need to counsel our patients on when prescribing these meds. So osteonecrosis of the jaw and atypical femur fractures are the big ones that people worry about. The studies show that the risk of these side effects are super low. Osteoporosis, necrosis of the jaw was seen in 5 out of 100,000 patients, and atypical femur fractures were seen in 2 out of 100,000 patients after 7 years of use. But there are things we can do to try and prevent these side effects, such as a drug holiday, which I'll talk a little bit more on the next slide. The other thing you want to do after starting a bisphosphonate is reevaluate your patient's bone mineral density every 2 years after starting it to make sure that they're increasing their bone mineral density and they're not getting worse. If they are getting worse after taking bisphosphonates, obviously assessed for medication compliance. And if they have been compliant, you want to think about referring to endo for a different therapy because they're likely failing the bisphosphonate therapy. And a fun fact I learned is that bisphosphonates can actually help with pain after a fracture. So they're not only therapeutic after sustaining a fracture, they can also help with pain, which I thought was kind of cool. So note on drug holiday. So after your patient's been on an oral bisphosphonate for 5 years or an IV bisphosphonate for 3 years, you want to think about a drug holiday to prevent some of those critical side effects, such as osteonecrosis of the jaw or an atypical femur fracture. So when you're evaluating them for a drug holiday, you want to consider whether or not they've had a fracture. And if the answer is yes, they've had a fracture, they're at very high risk for sustaining another fracture. So you want to continue the bisphosphonate or think about an alternative anti-fracture therapy, because the risk of another fracture outweighs the risk of some of those critical side effects I talked about. If your patient hasn't sustained a fracture, get a DEXA, and if their T-score is now still less than -2.5 and they're still in that high-risk fracture category, you want to still continue your bisphosphonates. If their T-score is improved, then you can consider going on a drug holiday. And then you want to reassess restarting the bisphosphonates every 2 to 3 years. The maximum recommended drug holiday is 5 years. Okay, so moving on into other treatments. So the next treatment I'll talk about is a medication called Denosumab. So if you turn your attention to the figure, it goes over the mechanism of action. So you have osteoblasts, which secrete a ligand called RANK-L, and RANK-L binds to the RANK receptors on osteoclasts, which help break down bone. And when this interaction happens between RANK-L and RANK, it stimulates osteoblast activity. So denosumab works by binding the RANK-L ligand and preventing it from binding to the osteoblast. So this essentially decreases the activity of the osteoclast. Denosumab shows similar increases in bone mineral density to bisphosphonates, but they're not first line because they can lead to paradoxical decline in bone mineral density and rebound fracture if used for short-term therapy. So it really should only be used for your patients with CKD who can't get a bisphosphonate. And you really need to be careful when prescribing this to your patients because you want to explain to them that denosumab's a shot once every 6 months and they need to stay on schedule and remain compliant with it, because if they're not, that can put them at a high risk of a rebound fracture. From what I've seen in the literature, denosumab therapy for 10 years provides good long-term protection against osteoporosis. Some contraindications to denosumab are hypocalcemia, and then some side effects to counsel your patients are mild GI upset and increased risk of bacterial cellulitis. So back to our case. Based on your patient's T-score of -2 and her FOX score of 23%, she meets criteria for osteoporosis. You order basic labs. Her CBC is normal, her kidney function is normal, her calcium is normal, and her vitamin D is normal. So what would you like to do for this patient? Oh, okay. So it looks like most of you chose start an oral bisphosphonate. So it certainly wouldn't be contraindicated to start an oral bisphosphonate in this patient. But if you remember from an earlier slide, the patient has a history of GERD, so starting an IV bisphosphonate would probably be better just to prevent the risk of pill esophagitis. Okay, so moving on into some more pharmacological treatments, there's PTH and PTH-protein analogues. These agents are anabolic, so they help stimulate the activity of osteoblast, and they're used in individuals with severe osteoporosis. So if your patient has a T-score of -3.5 or less, they would qualify for PTH therapy. If they have a T-score of -2.5 to -3.5 and they've sustained multiple fragility fractures, that's when a PTH analog would be indicated to start. If your patient's failed bisphosphonate therapy after 2 years of compliance, that's when you'd also want to start thinking about starting a PTH analog. And failing bisphosphonate therapy means that your patient was compliant with their bisphosphonate for 2 years, but their bone mineral density continued to decline. And once PTH-protein analogs are started, you can use them for 18 to 24 months, and you want to use them in sequence with bisphosphonates. And the reason for this is because if you stop the PTH analog and don't start the bisphosphonates, it can lead to rapid declines in bone mineral densities. Some side effects are nausea, headache, dizziness, and hypercalcemia. The next treatment I'll talk about is Romolizumab. Romolizumab is an anti-sclerostin human monoclonal antibody. This is another anabolic agent as well. It works by stimulating bone formation, inhibiting resorption. It's also recommended for individuals with severe osteoporosis, specifically individuals with a T-score of less than 2.5 and a fracture. The American Academy of Clinical Endocrinology recommends use of romolizumab for 1 year in sequence with the bisphosphonate. The reason why this medication is only recommended to be used for 1 year is because the long-term safety of it hasn't been established. I believe the literature showed that there is an increased risk of stroke or MI with prolonged use. So this medication also isn't recommended for individuals who've had a stroke or a myocardial infarction in the past. So a note on some other medications that can be used for osteoporosis, but aren't really used for a number of reasons. There's raloxifene, which is a selective estrogen receptor modulator. It can be used in women who can't tolerate bisphosphonates and denosumab to prevent vertebral fractures, but it doesn't prevent other types of fractures. So it's definitely not the best agent for osteoporosis. The other thing about raloxifene is it increases the risk for blood clots. So you don't want to give it to your patients at risk for a blood clot, stroke, or heart attack. But the one kind of cool benefit is that it's shown to provide some protection against invasive breast cancer. The other medication is hormone replacement therapy. The Women's Health Initiative did show that if patients were treated with hormone replacement therapy for 5 years, there's a pretty significant decreased risk for developing osteoporosis. But the problem with hormone replacement therapy, as I'm sure all of you know, is that it increases the risk of heart attack, stroke, or blood clot, as well as breast cancer. So the conclusion of the Women's Health Initiative was that the benefits of hormone replacement therapy don't outweigh the risks. However, the American Academy of Clinical Endocrinology says if your patient's less than 60, is 10 years, less than 10 years away from menopause, is at low risk of a DVT, and they can't tolerate bisphosphonates and denosumab, and they're also having bothersome vasomotor symptoms, you could consider giving them hormone replacement therapy. So in this very specific group of people, it would be reasonable to give it. The other medication that's not really used for osteoporosis is intranasal calcitonin. There's some data out there that shows that it reduces vertebral fractures, but the interesting thing about this medication, the reason why it's really used is because it can't help with pain after an osteoporotic fracture. But it's only really used in the short term as well because the long-term safety of this medication has not been established. So now that you're all experts in osteoporosis, you're probably wondering when you should refer to a specialist. So per the American Association of Clinical Endocrinology, you should refer to a specialist after a fragility fracture. You should refer to a specialist when a patient with a normal bone mineral density experiences the fragility fracture. When continued bone loss occurs despite receiving appropriate therapy. So if your patient fails bisphosphonate therapy, you should refer to the specialist to start a PTH analog or romolizumab, and probably don't want to do it yourself because they're just a little bit more severely sick and should be monitored by a specialist at that point. The other thing is when your patient has a comorbid condition that complicates management, like chronic kidney disease, that would also be a reasonable time to refer to a specialist. Okay, so back to our case. The patient returns to clinic 3 years later for follow-up. You order a repeat DEXA and her T-score is now minus 2.5 at her vertebra. What do you do? Most of you got it right. It's refer to an endocrinologist who will probably start a PTH analog or romolizumab. So a note about prognosis. Prognosis is good if detected on screening before a fracture, which is why screening for this disease is really, really important. There's increased morbidity if discovered after a fracture. Hip and vertebral fractures are associated with chronic pain and disability. And another note is women who sustain a vertebral fracture are at an increased risk of a second vertebral fracture in 1 to 2 years. And another thing that I'd really like to emphasize to all of you is osteoporosis tends to be severely undertreated. One study that I looked at depicted only 12% of women received post-fracture treatment 6 months after sustaining a fracture. So we can obviously do better than this. So just something to keep in mind. So my key takeaways from this is osteoporosis is underscreened and undertreated. We should evaluate postmenopausal women over the age of 50 for risk factors of osteoporosis and consider ordering Indexa before the age of 65. Prognosis is good if diagnosed before a fracture. And once the diagnosis is made, bisphosphonates are first line, and counseling our patients on fall prevention is key. So I just want to acknowledge Dr. Narla from the Department of Endocrinology for looking over these slides for me, because while I'm not an expert in this field, she is. So just a shout out to her, and then a shout out to Renata for helping me with this presentation on the teaching elective, which has been really enjoyable. Highly encourage all of you to sign up for it. Here are my references. And does anybody have any questions?
Fantastic. Thanks so much, Jaspreet. There's a couple questions that rolled into the chat, or I guess a question and a comment. Tinny asked, is the up to 10 years for bisphosphonates because that's as far as our current data goes, or is there evidence of loss of efficacy / side effects after 10 years of use, i.e. should we be looking out for long-term data studies on maximum duration of use?
Sorry, I was like, I should read that.
Basically asking
so
like
the main
10-year
reason for 10 years is due to the critical side effects that we're worried about.
Gina commented that sometimes she's experienced pushback from insurance with IV bisphosphonates, saying that the patient has to quote unquote fail oral before starting IV, and that is something to keep in mind that others might experience.
You know, I don't know how recent that was for you, Gina. I very recently put a patient on an IV bisphosphonate, and the insurance came back. It was Medicare and was like, you don't need approval for this. Like, go ahead and start it. So I don't know if things have changed more recently. I don't know how recently you've had that experience.
Yeah, Gina says, I'm sure it's insurance dependent. This was within the last year. Leah says that she's run into that as well, but provided justification, they approved it. Those are all the questions I'm seeing in the chat. We've got a couple more minutes if anybody else has questions for Jaspreet. Great. Well, thanks so much, everybody. Thanks everybody that participated today. Our wonderful presentations from Adam and Jaspreet. And we'll see you guys all next week.